So a number of people have been asking to just have a little bit more of an explanation of our approach of how we want you to assess patients, both in our program and what we think is a great approach to assessment patients pre-hospitally in practice. There's not a lot of research done on paramedic assessment pre-hospitally or in general. This is our best thoughts about what is a good approach. There are other approaches that are good as well. We have developed this and have kind of refined it over my last kind of 10 years here at the college, working through trying to come up with something that's very cohesive and easy to follow through. So I'm going to walk you through that. There's other approaches and other opinions, and frankly, we just don't know enough through research to really give you a true, for sure, this is the best way to approach. So to start off, every patient is assessed. We assess the scene to see what kind of personal protective equipment we need, whether the scene is safe, the number of patients, the illness, nature of illness, or nature of injury, frankly, help us decide whether this is a trauma or a medical patient. If we need additional resources to manage either one really sick patient or a patient or multiple patients, and if there's any energy applied to the patient that we might be concerned about C-spine precautions, that we could assume C-spine precautions if that was present. Then we'll follow through with a quick assessment of level consciousness, airway, breathing, and circulation. And usually when we walk in a room, most of the time, the patients are sitting up and talk to us, and we are able to introduce ourselves and say, "Hi, my name is Matthew, I'm a paramedic. What's going on today?" And they react to us quickly, and they talk to us. We can assess how, do they have any evidence of shortness of breath? How much pain do they seem to be in? We can look at their skin color, their kind of general appearance. And airway and breathing are kind of taken care of in that conversation. And if they're able to speak to us, we're just going to look and see what tidal volume looks like. But if they're able to speak to us in easy, full sentences, there's no question that airway and breathing are adequate. We'll put a quick hand on a pulse just to feel rate, rhythm, and then continue on to assessment. Now, if we walked in and found a patient that doesn't interact with us as appropriately, that doesn't instantaneously as we walk in the room go, "Oh, hey, how are you? Glad to see you," then we need to be very thorough in the assessment of level of consciousness, ABC. If we walk up and we see no signs of life, then we should check for a pulse first. If we see patient breathing in a coordinated manner, we can assess level of consciousness and feel go through loud verbal stimuli, painful stimuli, and see what they respond to, if they respond to anything. Then we need to be very deliberate to look in the airway, actually visualize the posterior pharynx and suction any secretions that are there, and consider putting an OPA or an NPA in to the patient, or holding manual maneuvers for the time being if you have hands to do it. Then we need to consider breathing very specifically. We could delegate a partner to get an oxygen sat on very quickly, which is informative for a room air saturation. Maybe consider some supplemental oxygen depending on the patient, treated differently for those with chronic lung disease, and goal kind of target sats for cardiac patients as well. But we could get a room air sat and consider starting to prepare some oxygen for them if they're the appropriate patient. We need to assess minute volume. We need to look and see, do we have adequate chest rise and fall that's going to sustain them for life for right now? If not, we need to provide positive pressure ventilation. And normally with good two-person positive pressure ventilation, that's going to resolve. If it's a situation, I've given the example of a foreign body air obstruction or something else, then maybe we have to go directly to resolving that with direct laryngoscopy and McGill forceps. But usually we're able to manage just with a single person bag valve mask with a OPA and maybe a couple of NPAs. And then we'd go on and feel for a pulse if we haven't already, and make sure that we have rate, rhythm, and volume present. Want to reiterate heart and strokes CAB approach. So if you don't see signs of life and coordinated breathing, poor skin color, we should be starting with CAB. So you assess those level of consciousness ABC in the incoherent patient much more in detail than the patient that's coherent and sitting up and talking to us, and really it's done in the first 3 seconds of our conversation. Then we have a decision point after those things are done. If you, just with circulation, if you had obviously no pulse, then we'd start compressions and defibrillate as per ACLS, and we'd obviously stop any deadly bleeds in a trauma patient. As far as a medical, there's a few other things like that we might look into for trauma patients, like open pneumothoraces and stuff in here, but it really needs to relate to airway breathing or circulation, and being about maintaining adequate opening of that tube, adequate minute volume, and adequate pulse. So after we make decision, is this medical or trauma patient? If the patient is coherent and been having a full conversation with you, then you go through and walk through their chief complaints. We've kind of organized that through OPQRST, and then walk through past medical history with AMPL. The past medical history is going to be detailed. We're going to ask about diagnosed conditions, current symptoms that the patient may have had, and risk factors, and walk through all of the way through that AMPL. Then we'll do a detailed physical assessment based on the assessments that we've provided you, but they'll be very specific to cardiac, respiratory, neuro, or abdominal, or what have you, based on their chief complaint, so that you can walk through that. So after that's completed, you get a set of vital signs, and then we'll work on from there. So at that point, we're going to work through and figure out what our differential diagnosis is. We're going to think about the things that we're thinking it is today, or the other things that might be less likely. So all chest pains are not acute coronary syndrome, so we need to think through other possibilities, whether that be a pneumonia or a thoracic aneurysm or what have you, whatever you think fits the patient's symptomology. But I want you to stop, discuss with your partner what you think is going on as far as the patient's diagnosis, and then form towards a working diagnosis. And that working diagnosis might be one lead thing that you think I have overwhelming past medical history, overwhelming symptoms and signs in the physical assessment and in the history of today, of the chief complaint and the past medical, to kind of lead one. Or that could be a number of things. Abdominal pains are notoriously abdominal pain not yet diagnosed. So you're going to work through, come out with a treatment plan that's appropriate for all the likely candidates on your differential diagnosis list or your working diagnosis. Then you're going to implement a treatment plan that doesn't cause harm to any of the things on your possible differential list. And then you're going to work through ongoing medical assessment, which just is going to look at how's my treatment working, where is my vitals at now, how is the symptoms and the physical findings that may have changed, have they changed, and does the patient look like they're getting better or sicker? So if you were to come down through, once again, down through, instead of coming through to coherent and we go incoherent, rather than going to a conversation about their past medical history and their past medical history, you're going to go through a rapid physical assessment, kind of a quick 1-minute assessment to get an understanding. ACLS in different courses call this ABCDE, disability and exposure. But we're just going to expose the patient, understand, get a quick physical assessment. But this is very quick. And then we're going to get a skinnier history about what happened today using OPQRST. But lots of things aren't going to be appropriate. Onset, when did it start, etc. But you're not going to ask radiate, or probably not severity, to somebody that's unconscious or has a decreased level of consciousness. We're just going to assume that it's severe. After that's done, we're going to go through past medical history. If there's a family member or somebody that knows the patient that we can go through. And after that, we're going to get a set of vital signs. Once that's completed, so it's a much shorter assessment, usually done within 5 minutes of of seeing your patient initially. We'll have all those details, and we'll go on and work through what we think a differential diagnosis should be for this patient, what we think is causing the problem, and then work out a treatment plan and implement that treatment plan. But always pausing to think, what else could this be? Not just what do I think it is? What am I tunneled on? So this is just a better way, a safer way for patients to think about the other things that maybe you're not tunneling in as well. Be sure to bring your partner into that. So that covers off our medical side. So if we go over to our trauma side, we essentially have two approaches around the mechanism of injury. Is it a significant mechanism of injury or no significant mechanism of injury? So significant mechanism of injury, this is energy applied to all over the entire body. So these are car accidents, big falls, such events of that nature. Whereas no significant mechanism of injury, this doesn't mean, this is isolated trauma, usually to an extremity that we're not concerned about assessing the rest of the body. So this might be something dropped on the foot, a twisted ankle or knee of an athlete or something, where they weren't hit or struck, that we're not concerned about the rest of their body. So you have to use your clinical judgment. If you have any hesitation about the mechanism of injury and whether there's injuries elsewhere on the patient, then by all means use the one that's for significant mechanism of injury if you have any hesitation. For the significant mechanism of injury, you're going to do a rapid trauma assessment just like ITLS or PHTLS advocates for. You're going to then initiate rapid transport if you see signs of shock or other life threats interfering with airway, breathing, any evidence of shock, big bone fractures, tension pneumothoraces, other things of that nature. You're going to transport them immediately, get them on the road. Obviously, we'll address life threats that need to be addressed, such as second chest wounds or tension pneumothoraces. But we'd like to get on the road as quickly as possible to your local trauma center. After that, we're going to get a set of vital signs, and then get a baseline set of vitals, and then start to work through any past medical history and working through a secondary trauma assessment where we're just looking for any further evidence of trauma or things that we may have missed. Often the back is missed, so please try your best to try to do that and assess the posterior as well as the patient's anterior as well. So after that's done, we'll work through a differential diagnosis as to what is causing our symptoms. And in trauma, that can be a number of things. It's until you have a CAT scan or MRI, and you may not know. So we can surmise what we think and treatment plan that would be best for this patient, often including fluid boluses, TXA, splinting, other things. So we'll try to limit as much the treatment that's on scene as much as possible to those things that are truly life-saving at the moment. We'll delay things like vital signs and IVs unless the patient's trapped, but we'll get them on the road as soon as possible, and then we'll try to do as much for them on our route to the trauma center. Now, for the focused medical assessment, we're just going to evaluate their chief complaints. So if they twisted their ankle, you're going to look at their ankle. You're going to try to understand how it happened, where the injury is, where exactly it hurts, and get a good understanding of it. What aggravates it, what makes it, what palliates it. You'll do a detailed kind of physical musculoskeletal assessment of that injury and that location. And then you'll get a set of vital signs and evaluate their past medical history. Usually these are all done on scene. It's not going to be necessarily transported to a trauma center. You can walk through your differential diagnosis and develop a treatment plan that often includes some pain management for these patients that might have broken bones but isolated. No life-threatening injuries. And then ongoing assessment. So that's how we'd like you to address patients. The big thing when you're here practicing, and I found it to be a very useful way of approaching patients in real practice, not just in the simulated environment. But what we're trying to encourage you to do is not make decisions without having all the information, at least not making any decisions that could be wrong for some patients. So just if you walk in and see a patient that's in a wide complex tachycardia, I think we still need to open the airway, make sure ABC is good, get a quick physical assessment, get a set of vitals, and then think through the history, and then make an informed decision and make sure that this isn't something that we're tunneling on a VTAC and it turns out to be some acidotic condition or hyperkalemia that looks very similar. So just prevent some of those errors that could be made by having the full amount of information. So take 5 minutes, get the full story, supporting airway, breathing, and circulation, and then work on from there. For the patients that are talking, the target assessments are great to get lots of information that's pertinent to their chief complaint. And make sure that you're talking to your partner about differential diagnosis. This is a process that often we've skipped over too often, and we need to be more thoughtful about how we're arriving to our decisions in treatment for patients. And we need to be thoughtful about not just that wheezes get Ventolin, but what could be causing these wheezes. And this will help both with clarity of your decisions and confidence in your decisions that you're making the right decision, and also keep your patients safer, hopefully. So that's our overview for patient assessment.